Welcome. Thank you for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General. Today's program is part of our Disability Education Series, a special collaboration between the Blum Center and Mass General's Council on Disabilities Awareness. Before we get started, I just want to go over a few items with you all. Please note that ASL interpretation and live captioning are provided for today. This session is being recorded for educational purposes. If you're interested in viewing the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Please note that you are in listen-only mode. Everyone has been muted so we can hear our guest speakers today. If you have any questions for our guest speaker, you may use the chat feature, which is located at the bottom of your screen. We'll have time for them in the end. Only Blum Center staff, our co-hosts, and guest speakers will see your questions. Please do not share any personal medical information or questions in the chat box. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we'd like to ask you to help us complete. Your feedback is important to us as we plan future programs. Okay, so next I am going to introduce you all today's guest speakers. Joining us today, we have Drs. David Dredge and Dr. Brian Wishart. Dr. David Dredge is a pediatric neurologist at Mass General for Children. He is an assistant professor in neurology, the director of resident education for child neurology, and co-director of the MGH Pediatric Neuromuscular Program. He attended the University of Massachusetts Medical School and Carleton College as an undergraduate. He completed his residency training in pediatrics at Bay State Medical Center and residency training in neurology at Mass General. Joining us today, we also have Dr. Brian Wishart. Dr. Wishart is a pediatric physical medicine and rehabilitation physician at Spalding Rehab and Mass General for Children. He is board certified in pediatrics, physical medicine and rehabilitation, pediatric rehabilitation medicine, and brain injury medicine. He attended Lehigh University with a bachelor's degree in ecology and moved to Philadelphia and completed a master's degree in medical science. He then attended Philadelphia College of Osteopathic Medicine for his medical degree and completed a teaching fellowship focusing on functional anatomy and manual therapy. He completed a dual residency at Thomas Jefferson University Hospital and Nemours Alfred I. DuPont Hospital for Children in both pediatrics and physical medicine and rehabilitation. In recognition of National Cerebral Palsy Awareness Month, they join us today to give a talk on cerebral palsy. But before I turn it over to them, Zara Amir Hassini, our Disability Program Manager at Mass General, has a few words to share.
Thank you, Amy, and thank you, Dr. Dredge and Dr. Wishart, for joining us today. This is the third installment of our disability education series for our MGB community. And March 25th is recognized as the National Cerebral Palsy Awareness Month. It is a month dedicated to raising awareness for millions of people who are diagnosed with cerebral palsy, which is a neurological disorder that affects many people, many of our patients, and some of our employees across the system as well. So we are very happy to have our presenters today. Please enjoy and let us give us feedback on what other topics you would like us to present in the future. So we look forward to Dr. Wishart and Dr. Dredge presentation. Thank you.
All right, are we ready for me? All right, hi, I'm Dr. Dredge. I'm excited to have this opportunity. I was saying just a minute ago, I find teaching to the community a fun challenge because we have our own language that we speak in medicine, and we have to translate it into like English. So hopefully we'll do a good job. And I'm going to share my screen. Oops. All right. So here's so we're talking about cerebral palsy. These are sort of my main objectives. So first, I think we need to talk about what it is and some of the terminology we use to discuss some of the differences that we see in kids with CP. I'm going to talk about kids mostly. There are adults out there who also have CP, but I only do kids. We're going to talk about some of the causes, and there's lots of them. So we'll highlight a few. And then we'll talk a bit about what other things sometimes come with cerebral palsy. And then I have a few things to say about management, but the more detailed discussion on how you manage muscle tone and other aspects of CP will be Dr. Wishart after me. So what is it? So let's talk about the words, right? So cerebral is a word that comes from Latin for cerebrum, which means brain. So that makes sense. Palsy is an interesting word. So it comes from the Greek. So para is beside, and then luine, I think is how you say that, loosen. So this combined word says to disable one side, right? And that's interesting because we'll talk later. There are some forms of cerebral palsy where it is only one side, but this doesn't. That term doesn't apply specifically when it originated. But now this is how we use it. And then I think what happened is as people got lazy, they just turned paralysis into palsy, and that was probably in older English speaking countries. And so bottom line is basically what this means is there's some form of paralysis due to the brain. And so this is the medical definition. So it's a permanent condition that causes motor dysfunction. The term motor just sort of encompasses all aspects of movement, including coordination and balance and muscle strength, etc. So permanent motor dysfunction that affects muscle tone, posture, and movement. I'm going to talk more about those terms. And then caused by abnormalities or injury to the developing fetal or infant brain. So this is interesting. So cerebral palsy specifically is only referring to symptoms that start early in life. So older people can also have very similar symptoms, as we'll talk about, and caused by trauma or strokes or other things that can cause brain injury. But we don't use the term CP for that because it's not during brain development. And then the deficits that we're going to talk about are permanent, but they don't usually get worse. And the sort of exception to that is in early infancy. So early infancy and childhood, things evolve in a way that's somewhat predictable, and it looks like things are getting worse, but it's really just as the brain matures, that maturation is not going as it should, and so things start to show up that you might not see early on in life. So usually once you get past like early school age, it's pretty clear that things are what we call static, or not changing. Progressive disorders there's a huge list of those, and that's not really pertinent to today's talk. But cerebral palsy really, I mean, it's a description of a syndrome. It's not really a diagnosis because many different things can get you there. And then, so we're going to talk about a few definitions of terms I'm going to use a lot. So tone, so muscle tone is one of the most important features of CP is changes in muscle tone. And muscle tone is a hard thing to explain and describe. And really, honestly, the best way to figure out muscle tone is by feeling it. So if you guys have patients or kids who are on this talk, you'll see, you know, we do a lot of movement of arms and legs and look at the trunk and holding up their head. And so all that is looking at tone. And so the definition we call it's the amount of tension or resistance to movement present in muscles at rest. Okay. One way to think about this is if you're close to a flat surface, and if you lay your arm at the elbow down with your palm up, for most people, you're going to see your fingers are a little bit flexed, so bent, and the wrist is a little bit cocked back or extended. So that's a normal resting posture of your arm, and that stays in that position because of muscle tone. So now if you imagine that all of your fingers were wide open and like touching the table and floppy, that's low muscle tone. If you imagine that you're squeezing like a fist, that's high muscle tone. And then the muscle tone is not the same thing as strength, because strength is really about your muscles moving part of your body against gravity or against resistance. And not everyone with cerebral palsy has weakness, but it can be a little bit challenging to tease out what's what. And that's challenging even for doctors and not just for patients and families. So what's posture? Posture is just your sort of resting position of your body in space. So standing up, sitting, you have some muscle activity while you're laying down. So all of these are postures. And to maintain a posture, you have to have adequate muscle tone. And so there are many sort of postures that we see in patients with cerebral palsy that are not expected or not normal. So we'll talk a little bit more tone, a little bit more about tone. So muscle tone can be increased or decreased in cerebral palsy, and often changes from decreased to increased over time. Muscle tone is a hard thing in babies because it moves very fast and it changes. And so many babies who have cerebral palsy early on might be low muscle tone. And as their brain matures, we start to see increasing muscle tone. And one of the key features of cerebral palsy is increased muscle tone. So the first year of life, though, so as I mentioned, sometimes you can't see that there's an issue until kids are halfway through their first year, and sometimes even later with some of the more subtle things. And so we see newborns and early infants who have had brain injury can be floppy, but that changes over time to increased tone. And so, and conversely, there are some healthy newborns who have increased muscle tone, and that just sorts itself out through the first year, and often in those circumstances just goes away. So most people don't really want to make a definite diagnosis of cerebral palsy until at least a year of age. Now, there are some cases where things are pretty severe and can sort of predict how things are going to go earlier than that, but I tend not to use the term cerebral palsy before a year because things change. So just some pictures to sort of get a sense of what tone is like. So low muscle tone. So in babies, we do these maneuvers to check tone. So this thing is traction response. So you're pulling the arms and seeing how well they can control the head. So this baby has very low tone. They can't really pick their head up. And what we want to see is that the back of the head is almost in line with the spine. We allow for a little bit of backward movement, but not this complete, what we call head lag. And then, so babies, we hold them under their stomach and see what happens to their arms and legs and their head. So this person, that arms and legs are dangling down, and they're not really lifting their head up against gravity. And so in a kid with normal tone, usually there's flexion of the arms and legs when they're upright, and then there's an effort to keep the head in line with the body. They're not always able to, but they at least make effort. And this is just one more of the maneuvers that we use. So we pick the kids up under their shoulders or in their armpits. And kids who have low muscle tone will sort of slip through your hands, so the arms go up and they're not maintaining tone. Kids who have increased tone tend to be very stiff there. So tone is the easiest to assess in babies, and part of that is that their repertoire of movement is low. And so there's only so many things that we can ask them to do. So there are ways to sort of there's signs of low muscle tone that you can see just by looking at kids. But again, out of the newborn period or the infancy period, you got to feel the muscle tone. And then you got to feel a lot of kids' muscle tone to get a good sense of what's normal and what's not normal. So these are some things. People use this term W sitting. If you see this kid is sitting and his legs and knees are turned outward, and it looks like a W. So W sitting is like a low tone thing. And then here you see sort of this sort of hunched posture. This is sort of like a descriptive thing. So head leaning forward a little bit, there's roundness of the back, the pelvis tips back. So these are some of the signs you can see in older people with low muscle tone. But again, it's a little bit more challenging. High muscle tone. So these are babies that are described as stiff or tight. And so tone is hard, not only because it's difficult to tell the difference between normal tone and abnormal tone, but there are also different types of abnormal tone. So the first one, and the one that actually is most commonly seen in cerebral palsy, is what we call spastic increased muscle tone. And so spastic basically means that the muscle tone will go up as you, based on how fast you're moving the joint. So the way to think about that is, say you're arranging someone's arm. So you're moving the arm to an extension and then flexing back in. And so if you're going from flexion to extension, if you do it very slowly, it'll be tight but fairly smooth. But if you do it fast, there's this catch. And so there's a brief increase in tone as you arrange the joint more rapidly. And most of the time when there's spastic muscle tone, there's also very hyperactive reflexes. So when we tap on kids' knees, they bounce pretty high, and they can have abnormal reflexes that shouldn't be there, which can be a clue. There's dystonic increased muscle tone. So this is different, and so it's unusual postures that are sustained, and they can be like permanent or episodic. And usually they're movements that change the position of the joint in an unnatural way. So like twisting an arm or the neck, extended way back. And it usually happens when what we call antagonist and agonist muscles are working at the same time, right? So when you flex your bicep, your triceps is not going to activate. It's because you want to move the arm up. So if both happen at the same time, it's going to be an unnatural movement and position. And then there's rigidity, which is sort of the tone is elevated throughout the range of motion without this sort of velocity dependence. And this is not really part of cerebral palsy. This is something we see in things like Parkinson's disease. And most of the kids with CP have spasticity. And so just a couple of like sort of common things that we see. So this kid down here, the things I want you to notice is that his arms are flexed, so the biceps are flexed. His arm is turned, so the palm is facing down, so we call that pronation. And the wrist is a little bit flexed, and his fingers are flexed, and it's tight. So this is a kid I tried to move. It would be pretty tight. Sometimes the legs are tied in this position, like a flex position. Sometimes they're in more what we call an extension. And sometimes the tone is very high in the muscles that move the hips in and out. And this can lead to this sort of foot position that people use the term scissoring. But there's a sort of certain muscle groups that tend to be more affected in children with cerebral palsy. So we talked about this. So the spastic type of cerebral palsy is velocity dependent increased tone. Another type of cerebral palsy is dyskinetic. And so in these cases, tone is usually abnormal as well, but they have very unusual movements. So sometimes they're like twitching movements, sometimes they're more like writhing, like snake-like movements. Sometimes it's dystonia, which I mentioned before, which is like a sustained twisted posture. This is less common. And then the least common form of cerebral palsy is what we call ataxic. So ataxia is a disturbance of balance and coordination. And these are the ones that sometimes will have low muscle tone. And this one is pretty rare. But a lot of kids have some of both or some of all three. So it's not always as clear. And so just for what I'm going to talk about next, I just wanted to give you a little bit of a sense of the anatomy because it kind of matters. So this is a drawing of a brain. So this is like a whole brain. This is on the outside. And these stripes, these colors are showing the function of parts of the brain. This part here, this is called the motor cortex. So this is the part of you that tells your body to move, right? And the signal starts here, but it has to go all the way down into the spine and then out to whichever part of your body is supposed to move. This picture is like you're looking face on into the brain. So this is the right side of the brain. This is the left side of the brain. The things I want you to notice are this strip of darker colored tissue is called gray matter, and this is where the nerve cells live. This lighter color is called white matter, and this really is like, think of it as like the cables taking the electricity from the cells and then down into the brain. And then here is a group of important parts of the brain called basal ganglia that mostly do a lot of regulation of movement. And then that motor cortex or motor strip that I mentioned, it actually is organized in a very consistent way across all people. So certain parts are responsible for moving certain parts of the body. So, foot, legs, arms, face. And this is relevant in some of the patterns of cerebral palsy we're going to talk about. So another way we think about this is which parts of the body are affected. And there's basically three main forms. So one is called hemiplegic or hemiparetic. This means only one side of the body has abnormal movement and muscle tone. And this is usually from things like a stroke or a problem that just happens on one side of the brain. And when there's injury to the brain, it's usually the opposite half of the body that's involved. So because the left side of the body controls the left side of the brain controls the right side of the body and vice versa. This is called diplegia. So just two limbs are involved. And so this is just the legs. This is common in premature babies. We'll mention that briefly. And then we use this term quadriplegia or quadriparetic when all four limbs are involved. So it's a relatively common thing. 2 per 1,000 is actually quite a high number for some of this stuff. And it really can be caused by anything that causes injury to the brain. The most common ones are prematurity and some of the complications of prematurity. this perinatal hypoxic ischemic brain injury. So this is when something during the labor or delivery goes wrong, and for a period of time, the baby doesn't get enough oxygen to the brain. Infections happen in the womb, and then sort of genetic and genetic brain malformations are often present. Those are going to be there before birth, but that are uncommon but important causes of cerebral palsy. These can have strokes. In kids, the most common times to have strokes are as newborns. Brain hemorrhage, illness outside of the womb. So if it's a sick baby, and then hyperbilirubinemia. So this is the jaundice thing that we check. Before there was aggressive treatment for jaundice, this could lead to a dyskinetic form of cerebral palsy. So we'll run through a few of the more common diagnoses. So a premature infant is one that's delivered before 37 weeks of gestation. And so normal is 38 to 40. And just being premature without any of the other issues is a risk factor for developing cerebral palsy. And that risk correlates with how young the baby is. So the ones that are born before 28 weeks, it's about 8%. And that number goes down the older they get. And so not so common in the 36 to 38 range. And again, so this is one of the common forms of brain injury. And so again, I show you this picture. So this part of the brain is where messages that move legs go down in the deeper parts of the brain. This is a normal brain, and you can see that strip of different colored brain tissue. And these little dark slits right here are called ventricles, or they're fluid-filled spaces that cushion the brain and circulate some nutrients and chemicals. This is a baby who has a form of brain injury called paraventricular leukomalacia. It's a big word, but basically it just means that the tissue around the ventricle is damaged. So this is a ventricle. As you can see, it's way bigger than this one. So already there's some loss of brain tissue. And then here, this is all areas that have been damaged and the cells die and sort of get reabsorbed. So this is basically brain has been replaced by fluid. And the location of this is in the leg areas mostly. And so, and there's a lot of factors that contribute to this, but babies, when they're in the womb, the placenta is controlling their blood flow and their nutrient delivery and all of that. And so if you take them out of that environment too soon, they don't have the adequate measures or mechanisms to accommodate for changes in blood flow. And sometimes there's also infections or inflammation or problems with the placenta that can make this more likely. The other thing that happens with premature babies a lot is they bleed. So the younger babies are more likely to bleed. And again, this is because they can't regulate blood flow to the brain very well. And there are different forms of it. This is a little hard to see, but I think you can see in this one. So this is the brain as if you were like looking from their toes to up inside their head. And so these are those ventricles in a different position. And so right here, there's some little dark spots. So that's actually blood. So this is the lowest grade of a hemorrhage. And then there's this part here. So this is in the ventricles, but ventricles are normal in size. And then this is a more severe form where the ventricles are actually a bit too big. These are ultrasounds and they're hard to see, but this one is a face-on view like I showed you before, and this is blood in the actual brain, so not just the lining of the brain or the ventricles. And so premature babies are at very high risk for this, and it's one of the things that can be a bigger complication for preemies. So then there's the thing we call neonatic hypoxic encephalopathy. So this happens when babies don't have enough blood flow or oxygen delivery to the brain. Most of the time, there's not a specific thing that we can point at. Problems with the placenta are common. The placental abruption, meaning it's pulling away from the uterus too soon and it bleeds. And in some cases, kids get stuck. The umbilical cord gets wrapped tightly. So there's a lot of factors that can contribute to this. But the babies who have significant hypoxic ischemic brain injury are very sick from the get-go. So it's usually pretty clear that there's been some brain injury. This often shows up as seizures in newborns. And then in the last like 15 to 20 years, therapeutic hypothermia, so lowering their temperature, protects the brain. And so this is sort of standard treatment now for babies who we think have this HIE. We cool them for 3 days, and that seems to protect them from some injury. And then infections, there's a few that are sort of like unique to newborns. These are things that they catch while they're still in the uterus or the womb. And some of these sort of don't happen anymore because of vaccination. So rubella, which is German measles, is very rare. This is what rubella looks like, these dark rash. You guys have probably heard about Zika virus in small heads. So this term microcephaly, so this is a normal size head, and these are babies with smaller heads. And that's been found in kids with Zika virus. And then cytomegalovirus is a pretty common virus, and it can cause a rash. And it also can cause calcifications in the brain. And then you can also have illness and infection after they're born, and that can lead to brain inflammation and cerebral palsy. And then there are a bunch of different brain malformations that can show up. This is sort of more esoteric stuff. So this is what we call lissencephaly. So it's a very smooth brain. There's not as many of these sort of folds you're supposed to see. This is hemimegalencephaly, which one side of the brain is way bigger than the other and is usually not formed correctly. This is called holoprosencephaly, where part of the brain doesn't form. This is agenesis of the corpus callosum. Basically, there's a bridge that's supposed to connect the two halves here, and it's not there. It's schizencephaly, which is a split in the brain, so a cleft. And this one's more complicated, but basically there's too much fluid in the back part of the brain. So those are the main. There's more than this, but these are, I think, the main categories. Time is getting a little bit short. So just wanted to make sure that everyone is aware that the cerebral palsy really only describes the movement and muscle tone problems. But when you have brain injury, there's also a risk of having other symptoms. And so we do a lot of treatment of the associated symptoms. So chronic pain is one. A lot of the kids who have cerebral palsy are nonverbal, so they can't tell you when it hurts, and it's a challenge. Because oftentimes they are demonstrating discomfort in it, but it's just hard to figure out what's causing a problem. And we think this is maybe more common than it's recognized. Many of them will have learning disorders or intellectual disability, speech and language difficulties, epilepsy or seizure disorders are fairly common. Many of them have visual impairment. Some of them have hearing impairment. They can have behavioral issues, things like autism. And drooling is a big one. So a lot of these kids don't handle their oral secretions very well. Many have sleep difficulties. There can be orthopedic complications, and some do have trouble with controlling the bladder. So you'll hear this from all of us, but really to take good care of kids with cerebral palsy, you really need a team. And so you need physical occupational speech therapists, they need special programs in school. All these doctors have roles to play. Social workers are really helpful. And there's a bunch of community support groups out there that I think families find to be very useful. And what's my job? So most of the time what I do is I help make a diagnosis, and then I treat some of the stuff, and then I also know who to refer to. And then Dr. Wishart's going to speak more about the management of the tone. So what do we talk about? So it's pretty common. It's caused by injury to the developing brain. And the main features are abnormal control of muscle tone, posture, movement. And there are a lot of different ways that we see it and a lot of different causes. And these kids tend to need a lot more medical help. So I'm going to stop there and pass to Dr. Wishart. I think we're doing questions at the end of both sessions, so I will take my share off. Thank you.
Perfect. Thank you, Dr. Dredge. So I'm going to talk a little bit more on some of the symptomatic management and hopefully some of the kind of practical things that we deal with on a day-to-day. I think it's, that last slide was exactly what I was going to try to highlight, and sort of the transition here is that there's a lot that can go on. And I think that what's important also is our patients with cerebral palsy, as you saw from sort of the different types that can occur, can really have a huge range in terms of level of function. And it can range from a small stroke where there's a little bit of change in their tone and they're walking, and otherwise, really when we talk about this, it's really just those motor concerns and there's nothing else getting in the way of their learning, to much more broad injuries to the brain that are encompassing a lot more features. So these are the things that I'm going to sort of focus on today. There, of course, is plenty that we could talk about, but I think when we think about cerebral palsy, really that definition is about the motor injury to the brain, and those other things are associated and can be associated with it depending on where that injury is. But that definition of cerebral palsy can be relatively specific to a non-progressive injury to a developing brain that affects the motor strip. So we'll focus there in terms of treatment because we don't have 3 or 4 days to go over everything. So we'll start with spasticity. I'm not going to dig into this too much. I think Dr. Dredge did a wonderful job of sort of going through the different types and the different considerations when we think about different types of tone. How I like to describe it is we all have tone. We all sit here against gravity and we're fighting that gravity to some extent. And depending on which side you go, so our low tone kids are going to be a bit more susceptible to that gravity and be pulling down. Our high tone kids are fighting against that gravity more than we would want them to, and they're not getting that inhibition of that tone from the brain. So there's lots of different ways of treating high tone and spasticity in particular when we think about it. Classically, and years ago when I had given this talk and had this slide, it's been built in different ways. And so there's the idea that there's a continuum. We start on one end and we make our way the most conservative side, and we make our way to a more aggressive way of treating. There's been the look of it as being a pyramid. If we have one part that's sort of the base and that's what we're using, and then as things get maybe more severe, is how it felt, we go up to these other aspects. I think that there's a different way of maybe thinking about what we want to do with this. Stretching, bracing, therapy will always be a big core. That's going to be a big component of how we're managing high tone, how we're managing decreased range of motion, and when this type of spasticity or change in muscle tone is affecting our function, our gait, our use of our hands, our sitting balance, and those types of things. And so we utilize these different tools on a conservative basis. We're not utilizing any sort of medication or injections or procedures. And so they can be considered on that conservative basis. That said, there's no implications to it on a day-to-day basis. Stretching, therapy, there's a huge time commitment to these types of things. You're pulling out of school or you're pulling out of after-school activities and that sort of thing. And so they shouldn't be thought of as nothing. I think they're an important aspect, and they're something that's going to be a big part of our children with cerebral palsy's daily lives. But we need to think about them as a prescription, as a treatment, and as we're using those. Same thing with bracing. Bracing can be really useful, and we're going to utilize that. And we'll talk a little bit more about some of the big braces a little bit later. But we use them during the day to help with our function, with our gait. We use them to help with our positioning. There are also nighttime braces that will help with overnight stretching and that type of thing. But when I think about our tone, I think about it sort of in 4 different quadrants. So how we're going to manage it and where exactly that tone is. So you can think about it as a focal tone or generalized tone. And then from there, you can think about sort of our temporary treatments and our permanent treatments. And so depending on where that tone is in our kids with hemiplegia that maybe are more affected in their leg, that's a really focal tone. And especially as kids are young, even though the injury to the brain is non-progressive, it doesn't mean that our tone isn't going to change. You may see different level of tone or different presentation of that tone as we go through different growth periods, as we're doing more stretching or different activities, as our weight changes. There's lots of different reasons that we could see a change in the tone. But we want to think about that. So when we think about generalized tone, that's where we think about our oral medications. So first line is typically something like baclofen. There's other medications like tizanidine or Xanaflex. There's things like Valium that we sometimes use on a short-term basis. So a range of different medications that are available, but something that we would think about as a generalized treatment, and really when we have tone sort of throughout the body. Focal tone management is much more, typically when we think about this on the temporary measures, is more of our botulinum toxin injections. And so these types of things are wonderful because we can target exactly whatever muscle is tight. And if it's one muscle that's pointing our foot down, we can decrease the amount of tone in that muscle. And the hope is that the redundancy in the body, so there's multiple muscles that do really every motion we have with some slight variation, but that redundancy can pick up that slack. So if we weaken one muscle, a different muscle can help sort of do that same motion, especially once we've taken that abnormal tone out of the picture. This typically lasts about 3 to 5 months, is something that needs to be repeated. I personally like to reevaluate our kids after we've gone through our treatment and let it sort of wear off. There are certainly folks that get into a cycle and they're able to do it every 4 or 6 or 3 months, but it's usually after a couple rounds that before I will just schedule them on that type of basis. There are more permanent treatments that are available, and most of these lie within the surgical realm. So selective dorsal rhizotomies are where they go actually into the spine and clip some of the motor nerves that go from the back down to the legs. These can be really helpful, typically seen within the ages of 3 to 7 years old. And the expectation is that we're going to improve our children's function by, we usually say 1 level. 1 level doesn't necessarily mean a ton, but the hope here is if they're needing support to sit, that maybe we'll get them sitting independently. If they're walking with a gait trainer, maybe we get them walking with a rolling walker or crutches. If they're utilizing a rolling walker or crutches, maybe we can get them independent with braces. And that's sort of the expectation when we think about this selective dorsal rhizotomy. Often kids need intensive rehab after this, and it is a relatively intensive recovery period because it's a big surgery. Intrathecal baclofen pumps are another option, typically again for the lower extremities, as is the selective dorsal rhizotomy. This is somewhere where they actually deliver that baclofen directly to the spine, and it's a pump that sits underneath the belly and needs to be refilled every couple months. The nice part about this is you're not getting that first pass through the body, and it's not something that you have to take a medication once, twice, 4 times a day. It's something that is continuously given, and so you get a nice steady state of tone management. There are other procedures, orthopedic procedures such as tendon lengthening. I think about these as opposed to those last 2 in the general sort of permanent treatment. These other ones more on the focal permanent treatment. And so tendon lengthenings, you would target the hamstrings or the adductors that bring our knees together, or your Achilles tendon, to lengthen that tendon and give increased range of motion. It also changes that set point for that spasticity to fire, and so it does affect the tone somewhat. There are other things. There's something called a highly selective peripheral neurectomy. And this is thought of in my mind somewhat as surgical Botox or botulinum toxin. And the nice part about this is, again, you can really target a very specific muscle with this and just get the nerve directly to that muscle, and it's a permanent procedure. Often used on sort of either end of our tone management. So kids that are really focal and have one muscle that's a main issue, really helpful, or kids that are very tight and we use it more in a palliative pain management, functional, decrease that pain standpoint. And so instead of it going just across that board from stretching, and if that's not working, we do oral medications. We think of it more on this sort of scatter plot of what's appropriate for that child at that time. And of course, physical therapy, occupational therapy, that kind of stuff can play a big part, but there may be more generalized tone, and we think more that we're going to lean on that medication standpoint that we're seeing here. Or maybe this is a child that has failed sort of oral medications and we've moved to something like a baclofen pump. And so that's the primary thing that we're utilizing for tone management while still using some seating, positioning equipment, some infrequent therapy, as well as some other stuff. And so I think about it more in that big scope, thinking about that child and what would be appropriate at that time, as opposed to working down a checklist. So the other big thing that we sort of talked about there a little bit is our bracing. A lot of our children have increased tone in the lower extremities, and helping with their stability and their movement can be really helpful. There's lots of different components to this, but I think thinking about the big goals is what's important when we think about our bracing. So we really want to improve that stability, which can lead to increased safety and improved movement, increased efficiency. When we think about human gait, almost everything we do as we learn to walk from kind of 0 to 3 to 7 is decreasing the amount of effort and the energy that we put into moving our body forward. So we don't go up and down a lot. We don't sway side to side because that's more effort than what we would want. And so our children with increased tone are often putting through more energy in order to walk. And so if we can increase their efficiency, we can get them to do more without working so hard. Different deformities we think about in different ways. So we would love to correct them and get them to more typical patterning. And sometimes that's done with tone, with surgeries or Botox injections. When we think about bracing, sometimes we'll accommodate for those deformities, or we may be pushing on those deformities to try to get them into a better position. Assisting weak muscles, certain braces can help by kind of helping bring our toe up, can help as we lean into that plastic to push off and get some propulsion forward, and helping with our walking, and then improving alignment. And this can help prevent pain, can prevent further contracture down the road, can prevent injury or issues with walking. And so there's lots of different ones. Our foot orthotics or shoe inserts just sit within that bottom of the foot. We usually think about this with sort of improving our arch within our foot, holding the back of our foot into a good position. Supramalleolar orthoses or SMOs come up above the ankle bones there, give us a lot of support sort of side to side, and can help with different components within that. And then when we really want to affect sort of how we're bringing our toe up or how we're pushing our toe down, we really need to go to those ankle foot orthotics that come up just below the knee. And there's lots of different ranges and different parts that are ways of doing that. I think we'll leave for another time so we can capture everything. Equipment can be used in lots of different ways. You know, we talked a little bit with the bracing about sort of correcting versus accommodating. And I think about our equipment in sort of both of those terms. Often these children are developing in different sort of rates depending on what domain you're talking about. So our speech, our fine motor control, our gross motor control, our walking versus our sitting. We may need to accommodate a weakness in one of those areas so they can continue to develop in those other areas. I think a great example of this is if we have low tone or we have difficulty sitting, it's really going to affect our ability to use our arms by reaching out. It's going to affect our ability to learn how to eat from having a nice stable base and stable core so we can work on that feeding. So sometimes things like activity chairs and that sort that give us a stable base to sit with, support, can allow us to progress and continue to move forward with our fine motor control and our feeding while we're still working on those in terms of improving those on their own. Similarly with wheelchairs. Wheelchairs are often a hard thing to accept but especially in our young kids that are, 2 or 3, and they want to explore and learn that independence, sometimes giving them a wheelchair so they can start to do things on their own while still working on learning how to walk or stand and that sort, can give them that social component, can help them develop sort of that whole person as opposed to just focusing on one area. And so there's lots of different stuff that's available, and a lot of it's for positioning and safety. But I think about all of those different domains of development when we think about which one we need to use at a certain time. More of a specific concern that we watch in our children with cerebral palsy is their hips. This is something that, around age 2 or 3, we're going to start getting pictures of their hips, particularly if they have tight muscles within their legs. So our children have tight muscles in the adductors that bring the knees together and are not standing at a typical time period, are at risk of not developing fully that hip joint. And so due to sort of force is how we get the right angles within the hip. So we get this sort of turning in of the top of the femur into the pelvis. And that's what forms a nice deep hip joint and that right angle of the femur coming in. And if we're not standing and we do have increased tone, we can get a more shallow hip joint, and we can have risk of what we would call subluxation, where it's partially coming out, or full dislocation. And so what we follow, and what I typically follow, sort of in conjunction with our orthopedic surgeons, is something called the migration percentage. And what that really looks at, if you look at this picture on the left here, the left side of the patient, the right side of the picture, is how much of the top of this joint is outside. So this line coming up to the pelvis is outside of that hip joint. And so that's the percentage we're watching. Typically around 30 to 40% is when I'll refer to an orthopedic surgeon and ask them to evaluate. And sometimes they're moving to surgery sooner than later. Depends a little bit on the whole picture, and that's why we need a full evaluation. It's not sort of a guaranteed surgical intervention or anything. And so you can see here on the right side, we have, the right side of the picture, we have some of that hip coming out of the socket. And so we have an increased migration percentage. On that right or left side of the picture, which would be the right side of the patient, you can see it sitting sort of up and back. And so that would be a dislocation. That's somewhat of what we're trying to avoid. Once we see patients that have this, there's a big discussion as to what we should do. Surgery is always an option, but if they're not in pain and they're not having difficulty with their seating or their function or their skin, it's not necessarily something that we have to move forward to. And so we're really looking at these functional questions. Are there difficulties with transfers? Is there difficulty with cares and hygiene and that sort? Are we having difficulty getting into the appropriate position for seating? Or having issues with kind of pelvic alignment causing a potential scoliosis or something along those lines? And so this is something that needs to be discussed, because after it's been dislocated, depending on the timing, it can make for a difficult recovery and surgery, and it may not be successful. So I think it's something that needs to be further discussed. And the last thing I just want to talk about is the value and the opportunities available within adaptive sports. We have kids, again, on all spectrums, and we've had nice discussions with folks that have had cerebral palsy that have been able to compete. They've been able to play on their high school soccer teams and that sort. But the value of adaptive sports in conjunction with this and sort of this Paralympic idea where they're in parallel, which is where that term comes from, it gives them an opportunity to play with peers and potentially feel more successful and, move on to the Paralympics and national sports and all of those types of things, but make true connections with folks that are going through similar things as they are. And so I really push this, especially as our kids get a little bit older and they don't want to spend all of their time in therapy and the therapy gyms with other adults. This is a place that they can find that social component that is so important to child development and, continue to be active as we're going through. There's lots more I'd love to say on it. I want to leave at least 30 seconds for questions and finish on time. So thank you.
Thank you so much. We do have a question regarding resources. Are there support resources for caregivers to help them navigate access to healthcare?
Yeah, there's a number of things that I present to families. Some of them are specific to your location. So there's now a new organization, the Lynn Disability Network, for folks within the city of Lynn, that's really working on getting access to bathrooms and different community events for children with disabilities together. Also through the diagnoses. So I work in our stroke clinic. We have a really nice parent board through our stroke group, and we put together a whole education series. But there's different events where families get together and they're able to connect with other groups that are there. I know for our more involved children, we have our ICMP, which is sort of a nursing support group that helps coordinate care and kind of get the resources that they need from a medical standpoint. So it does depend a little bit on, I guess, sort of the diagnosis and your location and all of that. So they are out there. I don't necessarily have a big list right now, but yeah.
So I can mention a couple of things. So there's an organization called CHASA's Childhood Hemiplegia and Stroke. That one's pretty specific to people who've had strokes or have just one side of their body affected. And then there's the Cerebral Palsy Foundation, which is a big one. And March of Dimes is still out and about. So a lot of those organizations are able to help families find resources and can be good to get connected with.
Wonderful, thank you. We are at time, but before we end today's session, do you have any final thoughts you'd like to share with the audience?
No, I'm always impressed with the population and the families. And I think if, it can be really hard, especially early during the initial diagnosis and trying to figure out, there's so much that goes into caring for these children and just getting out of the house. But having high expectations and recognizing that there's so much that these children can contribute and give to society and to families and to each other. And so giving them those opportunities to participate and be part of everything. And one other group that I love that sort of speaks to that is Partners with Youth and Disability, Partners in Youth with Disability, PYD, that's in the area. And they really work on getting our children connected with the workforce and community and getting them out there. And so another great resource that's available.
Wonderful. Thank you so much for spending the hour with us. Greatly appreciate it. This is extremely helpful.
Thank you so much. And everything you guys do.
Yeah, thanks much.
And for those who joined today, thank you for joining us. As I had mentioned, today's session is being recorded. It'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Thank you so much, everyone. Have a lovely rest of the day.